All right, assalamu alaikum everyone. I'm Haleema Shafiq, a third-year medical student, and I'm going to be helping you with two topics today, airway resistance and pulmonary function tests. Okay, so the way we're going to progress with this session is that we're first going to talk about airflow and resistance, and then I basically have all the important points from this topic summarized on 2 slides, okay, so we can go through that. And then we're going to talk about pulmonary function tests, okay? And then we can discuss the important points from this lecture. And finally, we'll end with practice questions so you can see that how you're going to be tested on these two topics, okay? So keep in mind that I have checkpoints throughout this presentation where I'm going to stop and ask if you guys have any questions. But if you have a question and we're not at a checkpoint, please feel free to unmute yourself and ask, or you can write it in the chat. But I won't be able to see your question in the chat until I'm at the checkpoint, okay? So let's start. Basically, there are two main concepts that we have to understand before we can actually get into the airway resistance lecture. The first one is that in order for air to move from one location to the next, there has to be a pressure difference basically between these two locations. So for example, if we have location A, okay, and then we have location B. In order for air to move from A to B, there has to be a pressure difference. Otherwise, there will be no net airflow. Okay? So that's the first basic concept that we have to understand. The second one is that air always flows from an area of high pressure to an area of low pressure. So taking our example from the previous slide, if we have location A and we have location B, first of all, there has to be a pressure difference between these two locations. But the second thing, that for example, if the pressure is high at area A and low at area B, then air will flow from A to B. That's the diffusion principle, basically. Okay? Now let's talk about the breathing cycle, okay? So I took these pictures from a really good video by Bite Size Med, okay? And I'll put the link for that video in the notes section if you guys want to watch the video itself as well. So let's talk about the breath cycle. This is basically at rest, okay? So the person has ended basically their exhalation, and we basically took a screenshot of the lung right after the person finished exhaling, okay? So keep in mind the chest wall likes to basically move forward and outward, whereas the lung, because it has an elastic ability, yes, it can expand to accommodate air, but it will always want to come back to its original shape, okay? And that's going to be because of its recoil force. So you can see the green arrow shows that the lung wants to basically come back to its original shape, whereas the chest wall wants to basically push outwards. We can see that right after exhalation, or basically at rest, the pressure at the alveoli and the pressure in the atmosphere basically are equal. That's why there's no net airflow, and this is right after exhalation. Also, the intrapleural pressure, or the pressure in the pleura, is -5 right now. Okay, now the person basically has started inhalation. So what's happening? The chest wall basically moves outwards, okay? And the lung also follows. What happens to the pleural pressure is that basically it decreases to -7.5. Sorry, does somebody have a question? All right. So basically, the chest wall basically moves outward, whereas the lung, of course, follows as well because air is entering inside the lung and it's expanding. The pleural pressure drops from 5, like we saw in the previous slide, to 7.5. Okay, and we can see that the alveolar pressure is -1. We know that the diaphragm basically contracts as well and basically flattens during inspiration to, again, allow the lung to expand during inhalation and accommodate that extra air that's coming inside. Now, keep in mind, during this time when the person is inhaling, they're basically inhaling normally, okay? They're not under any sort of distress. They're just basically at rest and they're inhaling normally. So the volume inside the lung at this time is the functional residual capacity. When the alveolar pressure becomes -1, right? Because the lung is expanding, so is the chest wall. The diaphragm also contracts to allow more air to come in. The alveolar pressure becomes -1. Going back to our basic concept in the beginning, there is now a pressure difference between these two locations, and the pressure is higher in the atmosphere. So air is going to go from the atmosphere into the alveoli. Okay? That's what happens in inspiration. We take air in. Now, air continues to move from the atmosphere into the alveoli until the pressure in these two locations become equal. That's when basically there is no net airflow because the pressure in these two locations are now equal. And that's what we talked about in our first concept. There will be only net airflow if there is a pressure difference in two locations, okay? Now, if we're looking at the lung, the volume inside the lung is the FRC, which we had before inhalation as well. But now we also have tidal volume, okay? Which is now entering the lung because the person is inhaling normally. So this is basically what I'm saying is all here. One thing you have to keep in mind is that inspiration is an active process, which means that your muscles are actively contracting during this process. We talked about the diaphragm, for example. Exhalation, on the other hand, is a passive process. We'll talk about that now. Now coming to exhalation or expiration. Now basically the recoil force of the lung is going to act. Remember that exhalation is a passive process, which means that the recoil force of the lung is basically what's mainly acting to push the air out of the lung in the exhalation process. So the lung recoils, okay, and basically tries to decrease in its size. The pressure of the alveoli now becomes +1. Going back to our basic concept in the beginning, again, we have A, a pressure difference between these two locations, and B, the pressure is higher in the alveoli. So the air is going to flow from the alveoli outside into the atmosphere, okay? Because air always moves from an area of high pressure to low pressure. Keep in mind that the intrapleural pressure is, again, right now, -7.5. Just like in inhalation, the air will continue to flow from the alveoli, this time into the atmosphere, until there is basically the pressure in both locations is the same, okay? The only difference is in inhalation and exhalation is the locations, okay? So in exhalation, the air is going from the alveoli into the atmosphere. Notice that we basically lost that tidal volume that we have inside the lung because we basically exhaled it, right? And notice how the pleural pressure has now gone back to -5, okay? Now, what is basically this -5? This -5 allows or basically prevents the lungs from collapsing. So this is basically from Dr. Shams's presentation. It's the same thing, just the values are a bit different, okay? And we can go over this as well. So the main thing that you have to understand is the breathing cycle as well. The values themselves are not very important for you. You just have to understand the breathing cycle itself, okay? How everything works. So this is the end of expiration. We can see that the volume inside the alveoli and the volume outside is basically 0. So basically there is no net airflow because it's the end of expiration. You've already exhaled all the air inside the lung. The transmural, or basically the transpulmonary pressure is the intrapleural pressure is -5 here. And if you were to calculate the transmural pressure or the pressure across the walls, that would come out to be basically, oh wait, is this blocking? It would come out to be +5, okay? What's the significance of this +5? The fact that the transpulmonary pressure is a positive value means the lungs aren't going to collapse, okay? Or the airways aren't going to collapse, because we'll see forward in our lecture that sometimes you'll have a negative pressure inside the airways, which is why they will sometimes collapse and trap the air inside. This happens in a disease, and we'll talk about that later on. So that's why you should keep this in mind. Now, during inspiration, what happens is the pressure inside the alveoli becomes less or becomes negative. The atmospheric pressure is basically always 0. And so now going back to our basic concept again, we again have a pressure difference between these two locations, and B, the pressure is higher in the atmosphere. That's why the person is able to inhale the air. Okay, and so the air enters the alveoli. The direction of airflow is from the atmosphere into the alveoli. The pleural pressure basically drops to -8, and our previous example was -7.5, but that's not really important. Okay. Now coming to the end of inspiration, we talked about how there will be airflow until the pressure at the two locations is equal. So this is the same thing that's happening here. The atmospheric pressure was 0, and now the alveolar pressure is also 0. Okay, and that's why there is no net airflow. The intrapleural pressure is now -10. Coming to expiration, now we can see that the alveolar pressure is at +2. We know that the atmospheric pressure is 0. So again, the air is going to go from the alveoli to the atmosphere. Talking about our two basic principles again, there's a pressure difference, and the higher pressure is in the alveoli, which is why this is happening. Okay. This is again to show you basically the transmural or the transpulmonary pressure, which again has positive values throughout our breathing cycle. Okay, so here's +6, here's +10, and here's +10 as well. Again, the significance of this is that your airways are not going to collapse because the transpulmonary pressure is positive. Again, this will make sense when we talk about the pathologies or diseases later on in the lecture. Okay, so just to give basically a quick recap of our whole breathing cycle, let's talk about what happened in each phase. So the rest, inspiration or inhalation, and expiration or exhalation. So change in volume. Keep in mind when we say 0, we don't mean that there is no air inside the lung. No. What we mean is that there is no change in volume. So usually in the lung, if somebody is breathing normally, they're at rest, they're not under any sort of stress or they're not distressed because of any situation, they're going to be breathing normally, okay? So they're going to have functional residual capacity inside their lung. During inspiration or inhalation, that volume is going to increase by 500 ml, okay? So it's going to go from 0 to +500. During exhalation, we're going to basically exhale that 500 ml of air, so it's going to go back to 0. Okay, what happens to alveolar pressure? Like we discussed, at rest, it's 0, right? Now you're requiring a pressure difference, okay, and particularly a lower pressure in the alveoli in order for the air to come in from the atmosphere into the alveoli. So that's why it becomes -1. Air continues to flow from the atmosphere into the alveoli until the pressure becomes equal in the alveoli and the atmosphere, so it goes back to 0. Then during exhalation, now the pressure inside the alveoli increases so we can exhale this air. So the air flows from the alveoli into the atmosphere until, again, there is equal pressure in both locations. So it goes back to 0. Talking about pleural pressure, it goes from -5 to -7.5 in inhalation, and then back to -5 during expiration or exhalation. Okay? The transpulmonary pressure, basically the difference between the alveolar and the pleural pressure throughout the breathing cycle in a healthy patient will stay positive, okay? And basically this will prevent the airways from collapsing. This again basically is a diagram from Dr. Shams's presentation. So again, we can go through it quickly. Again, this is the volume of air that you're basically inhaling. Okay, so you're at FRC. At 0, you are basically at FRC. Then you inhale a volume of air, okay, around 500 milliliters or 0.5 liters. And then you basically exhale that air. Expiratory flow. So basically here you go from 0 to -0.5 because you're inhaling air. Okay, and this is expiratory flow, so it's in the negative value because you're inhaling right now. Then you're exhaling, so it's the plus 0.5, okay? And that's basically what this graph is trying to tell you. Alveolar pressure, like we talked about, goes from 0 to -1 in inhalation, and then it goes back to 0 when basically the pressure is equal in both sides, air has basically entered the alveoli. Then it goes to +1, so we can exhale, and it goes back to 0 once basically the air has left the alveoli, and now the pressure is same in both locations. Pleural pressure, like we talked about, goes from -5, which is basically at rest, to -7.5, or basically this is a bit more than -7.5, okay? And then goes back to -5 at the end of exhalation, or basically back at rest. All right, guys, so we discussed the breathing cycle so far. Do you have any questions from this?
No, thank you.
All right. Okay, sounds good. Moving on to the next part of this lecture. So now we're going to understand the factors that determine airflow through airways, okay? Before we can get to the details, we actually have to understand a few basic terms in this lecture, okay? Starting off with airflow. So what is airflow basically? It's volume of air that's flowing through the airways in a unit of time or per unit time, okay? Pressure at airway opening can also be called atmospheric pressure, but basically it's the pressure when the airways basically open at the mouth or at the nose. What is the pressure there? That's the atmospheric pressure. Then we have the alveolar pressure, which is pretty self-explanatory. It's pressure inside the alveoli. And the last one is the airway resistance, which is basically the resistance that the air feels when it's traveling through your airways, okay? Just a diagram representation of what we're talking about, pressure at airway opening and the alveolar pressure. So we talked about all of these terms. We talked about airflow, okay, with that volume of air moving through the airway per unit time. We talked about pressure in the alveoli and pressure at the airway opening. And we also talked about resistance in the airway. Okay, now we're going to talk about factors basically about resistance, or the resistance equation itself. So talking about the equation of resistance, we have some constants and we have some variables. So of course, these values aren't going to affect the resistance anyway because they're constants. They're not going to change. What is going to change is the variables, okay? And you have three. You have viscosity, length of the airway, and radius of the airway, and this is the most important. Why is that? It's because you can see here that in the equation, the radius has an exponent or a power of 4. So even a very tiny change in resistance will produce a very, very large change in resistance, okay? So viscosity and actually length show a direct proportionality with resistance. What does that mean? It means that as the viscosity of the air increases, or basically it becomes more thicker, the resistance to airflow increases. And that makes sense because if you have thicker air flowing through an airway, of course, it's going to basically face more resistance as it passes through, right? Similarly, if we talk about the length of an airway or of a tube, the longer the distance the air has to travel, the more resistance it's going to face while traveling through this airway. So the resistance is going to increase. Radius, on the other hand, actually shows an inverse proportionality, okay? So when the radius of basically of an airway increases, the resistance is going to decrease by 4-fold, which is why it's the most important, okay? Because even a small change in the radius is going to produce a drastic change in the resistance. So if we take the example of 2 and put it to the power of 4, you can see the resistance is going to change or basically decrease by 16-fold, okay? Guys, we finished one of the objectives in Dr. Shams's presentations. Do you have any questions here?
No, thank you.
All right, so we can mark this objective as complete then. So our second objective in the airway resistance lecture is to describe the distribution of resistance related to the branching division of airways. So we'll come back to this graph. Keep it in mind when we talk about these zones, okay? So zones in the lungs. You have two zones, the respiratory zone and you have the conducting zone, okay? What is a conducting zone? The conducting zone is also sometimes called the anatomical dead space. And why is that? It's because no gas exchange occurs in this zone, so that's why we refer to it as the anatomical dead space. It starts from the airway opening at the mouth until the terminal bronchioles, okay? Now, you can keep in mind that airways in the conducting zone or in the anatomical dead space are also sometimes called central airways. This is important because when you come to third year and you do pathologies of the lung, you'll do tumors. And you'll see that some tumors actually tend to grow in the central airways, whereas others prefer the peripheral airways, which are present in the respiratory zone. Now, what's important for you to know now is that in the conducting zone, the volume of air is actually very minimal. It's around 150 ml. The respiratory zone, on the other hand, is comprised of the terminal bronchioles, the respiratory bronchioles, and the alveoli. Airways in this zone are actually called peripheral airways, like we talked about. What you do need to know is that the respiratory zone actually holds a much larger volume of air, okay? And that's around 2.8 liters or 2,800 milliliters. Going back to the graph that I showed you in the beginning, you can see that in the anatomical dead space, we have a very minimal amount of lung volume, okay? It's still here. But as soon as you enter the respiratory zone, you can see that the lung volume actually exponentially increases, okay? So keep in mind these graphs, we'll come back to them, okay? And I want you guys to answer a question for me. What structure do you think has a higher resistance to airflow? The trachea or the terminal bronchioles? And keep this equation in mind when you answer the question. Okay. Someone answered bronchioles. Okay, terminal bronchioles. Okay. So let's discuss what the answer is, okay? The answer here actually is, we'll discuss it, but what you need to remember before we go to that is that when we talk about airways, we don't talk about them in terms of a generation. Sorry, we talk about them in terms of a generation and not a single individual airway. And what I mean by that is that the trachea actually has a higher resistance than the terminal bronchiole, okay? And basically, when we say generations, what we mean is that if you look at the trachea, you only have one trachea, and it's considered generation 0. Okay. Yes, the terminal bronchioles do have a lower resistance, but a lower radius, sorry. But if you see here, you'll see that you only have one trachea. However, you have 30,000 terminal bronchioles in the lungs. And when we consider the collective or total diameter or radius of all 30,000 terminal bronchioles, it's much higher than that of the trachea. Thus, the resistance in the terminal bronchioles is lower than that in the trachea, okay? So basically, just to quickly recap this concept, when we talk about airways, we talk about them in terms of generation, okay? So when I say terminal bronchioles, I'm not just talking about a single terminal bronchiole. I'm talking about the whole generation of terminal bronchioles, okay? All 30,000 of them, okay? Trachea actually has its own generation, which is considered generation 0, okay? Where the terminal bronchioles, there are 30,000 and they're called one generation, which is generation 16. You don't have to remember the generation. This is just to kind of help you. But remember the generation 16, which is the terminal bronchioles, is basically going to have lower resistance than the trachea, okay? Now, a point that I actually mentioned here is that I said that the upper airways, particularly the first 4 generations of airways, have the highest resistance, okay? And you must be wondering that why just the first 4 generations, okay? What's so particular about that? That's because when you go from generation 1 or generation 0 to generation 23, the diameter and thus the radius of airways decrease, okay? But the total diameter of a generation mainly decreases in the first 4 generations, okay? So as you go from generation to generation, yes, the diameter is decreasing, but you also have an increasing number of airways. So from generation 1 to generation 4, you basically have a decrease in the total diameter as you go from generation to generation. But after the 4th generation, the number of airways also begins to increase, okay? So it kind of compensates. Yes, your radius is decreasing, but also your number is increasing, okay? And so that number basically compensates, because if you consider the radius of each and every one of those airways, like we talked about in the terminal bronchiole, we said they have 30,000 of them. So if you were to add the radius, okay, or the diameter of all of these 30,000 terminal bronchioles, you'll have a diameter that's way higher than that of one trachea, okay? So after generation 4, yes, the radius decreases, but the number compensates. So you actually have an increase in total diameter and therefore a decrease in resistance. This is what this graph is basically trying to show you. You have the first 4 generations, okay? And then after that, you can see there's a decrease in resistance from here. And that's what we talked about. We said that from generation 1 to generation 4, you have an increase in resistance, right? And that's what we can see here, resistance per generation. But after that, because the number compensates, the total diameter begins to actually increase, and you have a decrease in resistance. And you can see here that in the terminal, basically, bronchi, okay, he wrote bronchioli, you can see that the resistance is very, very minimal, because like we talked about, we have 30,000 terminal bronchioles, and you add the radius or you add the diameter of each of those 30,000 bronchioles, you're going to get a very, very high total radius or very, very high total diameter. So very, very low resistance. Now, this graph actually is trying to prove one of the conclusions that we made initially, okay? That Dr. Shums wrote in his slides. Let me go back to the graph. Here. He said that the major site of resistance is in the upper airway, in the 80%, okay? Now you can kind of see that here. Here, this is the resistance from mouth to generation, okay? What we mean is that when we go from this generation to this generation, we add the resistance from here to here as well. And in this generation, we're considering the resistance from here as well, okay? Now you can see this is the segmental bronchi, okay? And till before the terminal bronchiole, like we talked about, till before this is all the conducting zone. After the terminal bronchi, we have the beginning of the respiratory zone. So we can see that mainly the resistance, okay, more than actually 80% of resistance is in the conducting zone, okay? Whereas after the terminal bronchi, okay, which is basically the respiratory zone, and where mainly the gas exchange occurs, you can see there's very minimal resistance, okay? So around 80% or around like almost 90%, we basically have resistance here. The respiratory zone only makes up around 10% of resistance. And that's actually a good thing because gas exchange is occurring in the respiratory zone. You don't want resistance there because you want efficient gas exchange. And that's basically what this graph is trying to prove to you, that actually 80% or more than 80% of resistance lies in the upper airways, okay, or in the conduction zone, the anatomical dead space. And the least resistance, around 20% or even less than that, lies in the respiratory zone, okay? Guys, is it clear so far? You want me to repeat something? Because I don't mind going back.
No, it's clear. Thank you.
All right. Now let's come to the second point here, which is measurement of resistance is a poor test for detecting small airway obstruction. What do we mean by this exactly? So let's go and see. We have something, basically what we're talking about here is silent lung disease, okay? When inshallah you guys come to third year and you study tumors in more detail, you'll see that some tumors, like I mentioned, like to grow in the peripheral airways, and some tumors like to grow in the central airways, okay? Now, we talked about how the number of terminal bronchioles was 30,000, okay? And so imagine if you have a tumor growing in the peripheral airways, and it starts to obstruct, let's say, around 5 to 6 of these terminal bronchioles, okay? Now you have a total of 30,000 bronchioles. If around 5 to 6 of them are obstructed, the patient isn't going to show any symptoms, okay? Because you don't have a significant amount of airways that are obstructed by this tumor. So that's what we say when we talk about silent lung disease, is because you have so many airways in the periphery, the patient won't show you considerable or significant obstructive symptoms. So you won't know that the patient actually has a tumor in the peripheral airways until it's too late. So that's why we don't measure the resistance, because it's a poor measure, okay? It can't tell us if there is a pathology, because there won't be any resistance, because there won't be significant symptoms, because not a considerable amount of airways have been obstructed. On the other hand, if you talk about the central airways, because you have like less in number, for example, you have one trachea and then you have like 2 main bronchi, you don't have a lot of them, okay? So the patient will show considerable obstructive airway symptoms if you have a tumor that's forming in the conducting or basically in the central airways. Also, we can answer this question, is that why can the respiratory zone hold more air than the conducting zone? when we were basically discussing these two zones, I mentioned that the conducting zone actually has a very minimal amount or volume of air, okay? Whereas the respiratory zone has a much higher volume of air, okay? And one way to think about this is because you have, for example, 30,000 terminal bronchioles, and if you were to take the collective diameter of these 30,000 bronchioles, they of course can hold a larger amount of air or a higher volume of air. Plus, combine that with the fact there's less resistance here as well, okay? That's just one way to remember this. So guys, we've completed the second objective from this lecture. Do you guys have any questions? Do you want me to repeat something from this lecture? Or sorry, from this section? Okay, great. So now we're going to talk about factors like lung volume, autonomic innervation, respiratory gas partial pressures, and hormonal agents and how they basically affect airway resistance, okay? These are all the factors, and we actually discussed viscosity in the beginning when we were talking about the equation of resistance, but these other factors are actually new, and let's discuss them in details, okay? Density and viscosity of air. We talked about how viscosity shared a direct proportionality with resistance, sorry. We talked about how viscosity and density basically shared a direct proportionality with resistance, which means when density or viscosity basically of the air increases, the air becomes heavier and thus the resistance faced by the air actually increases. It's harder for this air to pass through the airway because it's so heavy. So density or viscosity increases, that leads to an increase in resistance. Similarly, if the density or viscosity of the air decreases, the air becomes lighter. For example, you have the helium-oxygen mixture, okay? The resistance is going to decrease because this air is light and it can basically easily pass through the airway. So when the density or viscosity of the air decreases, the resistance, okay, is going to decrease. It's a pretty simple concept, this one. Okay. Reduction in PCO2. So basically, when the partial pressure of carbon dioxide is low, bronchoconstriction occurs and basically diverts or directs ventilation to other hypoventilated areas. And when you have bronchoconstriction, you're going to have an increase in airway resistance, like we talked about in the equation, because you're going to have a decrease in radius. Now, you need to remember that the lungs and the kidneys are basically two organs in your body which are going to maintain the pH. Okay? So if you have an area that is basically has a low PCO2, it can't lead to alkalosis, right? Because carbon dioxide is acidic. Okay? So if in some zone or some region of the lung, you have less carbon dioxide, that can basically lead to alkalosis in the part of the blood that's passing through that zone. So there's going to be bronchoconstriction to basically direct this air somewhere else, okay, and to basically maintain the pH in that particular zone. So a decrease in PCO2 basically, okay, or hypoventilation is going to cause bronchoconstriction and direct ventilation somewhere else, and bronchoconstriction basically is going to increase your resistance. Okay, let's come to the sympathetic and parasympathetic innervation. So we know that basically, when is our sympathetic nervous system mainly active? It's active when basically we enter a fight or flight state, okay? If, for example, if we're stressed about an exam or stressed about any situation, or we're in danger, okay, and we have to run or fight. So the flight or fight mechanism basically activates, and that's your sympathetic nervous system. Now, if you think about it, for example, if you're in a situation where you have to run, okay, you're running away from something or you're running towards something, doesn't really matter, okay, you're under stress and you have to run, okay? If you think about it logically, you're undergoing a fight or flight mechanism or fight or flight response. You're gonna need more oxygen inside your body, okay, so that you have more oxygens to your muscles so you can run properly, okay? You also need more oxygen for other organs to function properly so you're able to escape this dangerous situation, okay? So that's what the sympathetic nervous system basically does. The sympathetic innervation, okay, basically uses epinephrine as its neurotransmitter, okay, and causes bronchodilation. So you're able to breathe in more air, thus you're able to breathe in more oxygen, okay? And that basically means that bronchodilation is going to cause a decrease in airway resistance, okay? And that's why you're able to breathe in more air. Now, the parasympathetic nervous system is mainly activated in the rest and digest state. What does that mean? It means the person basically is at rest, okay? They're not under any sort of stress. They're simply just resting or eating. And there's no danger around. So right now, you don't need bronchodilation, right? You don't, because you don't have to run anywhere. You don't have to fight somebody. You're simply resting. So in the parasympathetic innervation, it actually causes bronchoconstriction. It uses mainly acetylcholine as a inhibitor, okay? And because it causes bronchoconstriction, it's going to increase the airway resistance. Sorry. Okay, the parasympathetic innervation is going to increase airway resistance because it causes bronchoconstriction. And again, the parasympathetic nervous system is activated in the rest and digest state. So you're simply resting and you don't need bronchodilation. You don't need an increased amount of oxygen intake. Now, you'll actually study all of these substances in way more detail as you progress through the years, okay? But for now, what you need to remember is that thromboxane A2, which is TXA2, histamines, prostaglandins, okay? For example, prostaglandin F2, they're all bronchoconstrictors, okay? So they're going to cause bronchoconstriction and basically lead to an increase in airway resistance. You guys may know histamines, okay? Because they're one of the main things that are released during an allergic reaction. So these might actually be familiar to you guys. But these ones you're going to do in more detail as you move on. So you can see that in an allergic reaction, okay, the patient sometimes has difficulty breathing. It's because when histamines are released in an allergic reaction, they cause bronchoconstriction and thus increase airway resistance. So less air actually is entering, and that's where they're having difficulty breathing. So sometimes you'll see somebody asking for an EpiPen, right? Because you're basically asking for epinephrine release, which causes bronchodilation. So like a simple summary of what happens, okay, in an allergic reaction. All right, now we're going to talk about lung volume, okay? So in this diagram, these small circles actually are your alveoli, okay? And the alveoli basically surround these two main structures. You have the bronchus, okay? So basically, we're taking a screenshot, okay? Of course, you have more bronchi and more blood vessels, but if you're taking a screenshot here, you can see that we have one bronchi and one blood vessel, and they are surrounded by alveoli. Now, what happens? The patient basically inhales an amount or volume of air, okay? The alveoli basically expand to accommodate this air, like we talked about in the breathing cycle, okay? And now, this person is getting ready to exhale. So what happens? The alveoli basically have their recoil force, okay? They start to close in on themselves to push this air out, like we talked about in the breathing cycle. So the recoil force acts, the alveoli basically close in on on themselves to basically push this air out during exhalation. Now, these alveoli, because they're surrounding the bronchi, okay, when they are basically closing in on themselves, they start to pull on the wall of basically this bronchi. So you can see basically these springs kind of attached to the wall of this bronchi. As the alveoli close in, they start to pull on the wall of this bronchi. And what does that lead to basically? It causes the bronchi wall to basically be pulled open, and that causes bronchodilation. Bronchodilation means there's going to be a decrease in resistance. So, quick recap, basically the alveoli recoil, close in on themselves, pull on the wall of the bronchi, okay, and cause bronchodilation and thus decrease resistance. Now, what you have to consider here is that the higher the lung volume the person is inhaling, okay, the more the alveoli have to close in on themselves, okay, or basically have to undergo recoil to push this air out, okay, and the more the wall of the bronchi is going to be stretched, which means an increase or like a greater degree of bronchodilation is going to occur. So the lesser the resistance. The more bronchodilation, the lesser the resistance. Okay. Basically, this is all what I've explained to you in the diagram. You can read this yourself. Oh, one thing to consider is that the recoil force mainly acts in the alveoli. It's one of the strongest or main areas where it acts. So a recap of this, or like a summary of this, that the larger the lung volume the person is inhaling, larger recoil force generated, and greater bronchodilation. So less resistance to air. And this graph basically shows you the same thing. So you can see that we have airway resistance over here, and we have lung volume, okay, here. So the greater the air the person is inhaling, the larger the lung volume, right? Because that means the larger or greater the amount or volume of air inside the lungs. So we can see here that at 4, this is the resistance. At 2, however, you can see that you have a much higher resistance, okay? And that's because of what we talked about before. You can also see that at 6, the resistance even has decreased even more as compared to 4 and 2. And same goes for 8 if we were to basically extend this graph further. You can see that basically it's going to be even lesser at 8. And basically that's all this diagram is trying to tell you. All right, guys, we've basically completed the third objective from the airway resistance lecture. Do you guys have any questions from this section that we just talked about? I don't mind repeating anything because basically all the concepts kind of built on each other. So as lung volume inversely proportional to resistance. Yeah, you can say that. Is lung volume inversely proportional to resistance? So yeah, the concept here is that the higher the lung volume here you have, the more bronchodilation you have, the lesser the resistance. You can think of it in that terms. Because inverse proportionality kind of falls within like equations and stuff. But if it helps you remember that, sure. Yes. Greater the lung volume, lesser the resistance. Does that answer your question? All right, guys, any more questions? I don't mind repeating any part, okay? Because the purpose of this PAL session is basically for you to clear any concept or basically answer any questions that might have, okay? All right, I don't see any other questions, so I guess we can move on. So we've completed the subjective. So this is the summary for basically this lecture. So let's just quickly go through these points, and if you have any questions from these points, we can go back and discuss it again. So factors that affect flow are changes in pressure and resistance. So remember the basic concept that we discussed, right? You need basically a change or like a difference in pressure for air to flow, and you need to have a high and low pressure, and that will determine the direction of airflow. Resistance mainly depends upon the length of airway, viscosity, and radius, okay, according to its equation. Change in radius causes a 4 times or 4-fold change in resistance. The respiratory zone holds more volume of air than the conducting zone, or the anatomical dead space, due to higher total diameter. And why do we say higher total diameter of the respiration zone also means that there is less resistance in this zone? Because we talked about how we're going to have a collective diameter. We're going to add the diameter of every single airway in a particular generation, and that's going to give you a total diameter. 80% of the resistance is present in the upper airways, and we talked about why that is the case, because we said that as you go from generation to generation, until generation 4, basically the radius decreases. After that, yes, the radius continues to decrease, but the number of airways compensate because those increase. And so when you add all of the radii, or basically all of the diameters, you're going to get a higher total diameter or a higher total radius. So actually, basically the diameter would increase and you'll have a lower resistance. Increase in density and viscosity increase resistance. Decrease in PCO2 increases resistance due to bronchoconstriction, and basically the air is going to be directed somewhere else. Sympathetic nervous system causes bronchodilation because we talked about the fight or flight mechanism, okay, thus decrease in resistance. Parasympathetic nervous system, okay, which uses acetylcholine as its neurotransmitter, okay, plus thromboxane A2, prostaglandin, F2, histamine, they all cause bronchoconstriction, okay, thus increase resistance to airflow. The higher the lung volume, the greater the recoil force generated, and the more the walls of the bronchioles are pulled wide, and the lesser the resistance. So guys, we finished the airway resistance lecture, and we went through all the important points from this lecture. Do you guys want me to repeat anything from here? Or do you have any questions from here that you want me to answer? So do we always have to consider the number of generations when determining resistance? Basically what the number of generation, basically trachea is generation 0, okay? Terminal bronchioles, for example, is generation 16. What you have to consider is the number of airways inside the generation, okay? Or what the generation consists of. So what I mean by that is, for example, if we talk about generation 16, and that's terminal bronchioles, you have 30,000 of them, okay? And if I were, like I asked you guys, trachea or terminal bronchioles, okay? You guys said terminal bronchioles. Basically, you have 30,000 terminal bronchioles. You add the diameter of all of them, you get a total or collective higher diameter, so a lesser resistance. That's what the generation tells you. Because sometimes what people do is that they only consider one airway, okay? They don't consider the generation. They don't consider 30,000 terminal bronchioles. They only consider one of them. So that's why I was trying to explain the concept of generations, okay? What I'm asking you is that you should consider the whole generation, all 30,000 of those airways, instead of considering only one terminal bronchiole. Does that answer your question? Yeah, just to further clarify, so for example, if you have, this is just basically I'm making this up. I'm not sure if this is anatomically correct. But for example, if generation 10, let's say, has 10,000 airways, generation 16, on the other hand, has 30,000 airways. Now, if I were to basically add up all of the diameter, okay, or all of the radii in generation 11, okay, and you only had 10,000 here, of course, the collected diameter here would be less than that in generation 16, because in generation 16, you have 30,000 airways, okay? So the diameter in generation 10 is less than, okay, the total diameter in generation 10 is less than that in generation 16. And that kind of tells you about your resistance. Okay, someone asked about questions. Yeah, I have questions at the end. Would you guys prefer to go over the questions now, or would you want to go over them at the end after we're done with pulmonary function tests as well? Okay, one person said to go through them at the end. Do you guys all agree with that? Do you guys all want to go over the questions after we are done with the second lecture as well? Okay. So we're done with the first lecture. Do you guys want to take like a 5-minute break before we start off with the next lecture? It's up to you guys. If you feel like you need a break from this, we can take a break for 5 minutes, then come back. If you guys think that you're up for it, we can start now. I don't mind both ways. Okay, so one person said to take a break, one person said that no break. So the rest of you guys also need to vote on what you guys want to do. Okay, we can take a 5-minute break, okay, and we'll come back after 5 minutes. So right now it's 8:08. We can come back at around 8:15. Are you guys okay with that? 8:15? It's a bit more than 5 minutes, but yeah, it works. So we'll come back, inshallah, at 8:15. Okay. I just quickly want to go over this point one more time because I think I may have confused some of you here. When I asked this question, okay, why am I not on full screen? Okay, when I asked this question about the higher resistance between trachea and terminal bronchial, some people might think that it's trachea because it has a higher radius than the terminal bronchial. And thus, the resistance should be less in the trachea, okay? The reason why the answer is not trachea, okay? 1 second. 1 second, guys. Okay. I think I realized my mistake. I meant to make this lower resistance, okay? But don't look at this question. Just in general, if you understand the concept of generations, is that you don't look at individual airways, you look at terms of generation. So if you're trying to determine if the resistance is going to be less you don't look at a single individual airway. You're going to look at a whole generation. Okay? So if you have a respiratory or like a terminal bronchiole, look at all 30,000 of them and then compare it with another airway, but not an individual airway, its whole generation, and the number of airways you have in that generation. That is going to help you figure out if the resistance is going to be low or high. And so because you have a higher total diameter in the respiratory bronchioles, because you have 30,000 of them as compared to the trachea, and because the total diameter of 30,000 respiratory bronchioles is going to be higher than that in the trachea, that's why the resistance is lower in the respiratory bronchioles. That question was supposed to be lower resistance. Okay. Let's start with our next lecture, which is pulmonary function test. Okay. So you have an instrument that we call spirometer, okay? This instrument actually is used to see if the lungs are working properly. Okay? And then using a spirometer, we also actually measure certain parameters that help us differentiate between two main categories of diseases. Okay? So we have obstructive and we have restrictive diseases. Okay, we'll talk about them in detail further as we move on with the lecture. So here, this is the graph from Dr. Shums's presentation. We have total lung capacity over here, okay? And then what we do here is that we ask the patient to take in a deep breath, okay? Once the patient has taken a deep breath, we ask them to do two things. A, to breathe forcefully, okay? And B, to breathe basically as fast as they can. So they have to exhale forcefully and they have to exhale as fast as they can. One thing that we measure is the 1 second capacity. So how much air can this person breathe out within 1 second? That is 1 second capacity, basically. The total amount of air they can breathe out is basically the forced vital capacity. Force basically is here because you're asking them to breathe out forcefully and quickly. Okay, this is actually a table from Medicosis Perfectionalis. Okay, and I'm just trying to show you the different parameters that we can actually measure. So what's tidal volume? We discussed that in the beginning when we talked about when a patient, sorry, not a patient, when a normal person or like a healthy person basically is breathing and they're at rest, they're not under any sort of distress or any stressful condition, they're breathing normally, that's the tidal volume. So basically normal inhalation, normal exhalation. That's what you're seeing here. Now, if we ask the person to take in a very deep inhalation or as maximal air they can inhale as possible, that's going to be the inspiratory reserve volume. If we talk about if we ask the patient to do expiratory reserve volume or exhale as much as they can, that's the expiratory reserve volume. When we talk about the 1 second capacity, you can consider it as like a subset of expiratory reserve volume. The only difference being here is that in 1 second capacity, okay, you're actually timing the patient. You're telling them, okay, you have 1 second, and I'm going to see how much volume of air that you can breathe out in this 1 second. But if we were to talk about expiratory reserve volume here, you don't really have a time limit. You just ask the patient or just ask the person, just breathe out maximally, okay? After a maximal inhalation. Vital capacity basically is a combination of the two. The expiratory reserve volume, the maximum volume of air the person can breathe out, and inspiratory reserve volume, the maximum volume of air the person can breathe in, okay? So if you combine these two volumes, you have vital capacity. The difference between a volume and a capacity is that a capacity actually consists of 2 or more volumes, like we saw here. Vital capacity is basically the sum of expiratory reserve volume and inspiratory reserve volume. Okay? Then we have functional residual capacity, which I believe you guys did yesterday in more detail, but just to do it one more time again. It's basically the sum of expiratory reserve volume and residual volume. What does it mean? Functional residual capacity basically is the volume of air that will stay inside the person's lungs, okay, when they are inhaling and exhaling normally. So they're at rest and they're breathing normally, okay? They're not exhaling maximally, okay? They're just breathing normally. So the amount of volume, okay, or the amount or volume of air inside their lungs is going to be the expiratory reserve volume plus the residual volume. And that's functional residual capacity. Total lung capacity is all of these volumes, okay, like you can see here. These are just definitions, basically, of what we just talked about for like future reference. And you can see that FEV1 is like a subset of ERV because it's maximum volume of air that can be forcefully exhaled in 1 second. So time limit plus force is being used here to exhale. Here, there's no time limit. So we talked about vital capacity, maximum volume of air that a person can exhale after maximal inhalation. FVC here, basically, forced vital capacity, is the volume of air that can be forcefully and quickly exhaled after maximal inhalation. So like a subset of vital capacity. But again, here you're using force to breathe out, okay? Maximum inhalation, forcefully breathing out and doing it quickly. FVC usually is a bit less than vital capacity because, again, they're using a bit more force, okay? So sometimes basically it ends up being a little bit less than vital capacity. We talked about tidal volume. We talked about residual volume. Remember that residual volume is always going to be present in your lungs. No matter what happens, this volume of air is going to stay within your lungs. You can't breathe it out. Okay, so now that we've basically discussed all these lung parameters, okay, can you guys tell me that what can spirometry measure and what spirometry can't measure, okay? So first of all, we have inspiratory reserve volume. Can you guys tell me, can spirometry measure this or no? Can you measure inspiratory reserve volume, the maximum volume of air the person can inhale via a spirometer? All right. People are saying yes. All right, good. Yes, it actually can. What about expiratory reserve volume, the maximum volume of air that a person can exhale? Can spirometry measure that? Okay, people are saying yes. That's correct. You can measure the maximum volume of air that a person is breathing out. What about residual volume? Can a spirometer measure this? Residual volume. Exactly. Because this volume of air never leaves your lung, the spirometer can't measure residual volume. Okay? What about functional residual capacity? Can a spirometer measure FRC? All right. Actually, the answer is yes, you guys are right. It's no, it can't. And why is that? Because if we were to go back here, FRC is residual volume plus expiratory reserve volume. It's the amount or volume of air present in the lungs when a person normally exhales. The spirometer can't tell you what ERV is, but it can't tell you what residual volume is, thus it can't measure functional residual capacity. Does that make sense? This is actually a question in our exam, in our final for CVP. The doctor asked us this, that he gave us options and he was like, what aspirometer can't measure? And FRC was one of the options. So I'm making sure that I tell you guys what it can and can't measure. Yeah. Okay. So talking about total lung capacity. Do you guys think that a spirometer can measure this? Yes, exactly. You can't measure total lung capacity because, like I talked about when I showed you guys the graphs, total lung capacity actually involves all of the volumes, right? Here. This is total lung capacity, and you can see it actually includes residual volume. So you can't measure total lung capacity via a spirometer. Okay, FVC, forced vital capacity. Do you guys think that a spirometer can measure this? It's basically the amount or volume of air that a person exhales after maximal inhalation. So do you think that a spirometer can measure this? Yes, it can. Because again, the person basically is maximally and forcefully exhaling, and a spirometer can measure that, exactly. Last one, FEV1. Can the spirometer measure this? Maximal exhalation within 1 second. Can a spirometer measure this? Yes, it can. All right, amazing job, guys. Let's just go to the answers. So I have basically them here for future reference, okay? So basically spirometry or a spirometer can't measure 3 things: residual volume, functional residual capacity, and total lung capacity. And the way you can remember this is because both of these actually involve residual volume, which is why you can't measure them using a spirometer, because the residual volume never leaves the lung. Okay, now let's come to diseases. So when in the beginning we were talking about a spirometer, okay, we talked about forced vital capacity and FEV1, okay? FEV1 is basically the volume of air that a person can maximally exhale within 1 second, okay? And forced vital capacity is the volume of air that a person can exhale after maximal inhalation, okay? When you take these two values and you basically do a ratio, you're supposed to get 0.8 or 80% in a healthy patient, okay? If this value is less or more than 80% or 0.8, that should tell you there is something wrong. There is a disease here, okay? Now, what disease, okay, corresponds to what value of this ratio we'll talk about. So here, you can see normal, okay, the ratio is 80%. Obstructive lung disease, okay, is a type of lung pathology, okay? And basically what you're going to see here is that your FEV1 to FVC ratio actually has decreased. It's 42%. If you look at restrictive lung disease or restrictive lung pathology, you will see that the FEV to FVC ratio has actually increased, okay? So obstructive and restrictive lung diseases are actually a broad category, okay? It's one of the broad ways of classifying the lung pathologies. When you come to Inshallah third year, you'll actually do it in more detail. So you'll study types of obstructive lung diseases and types of restrictive lung diseases. And when you solve questions, one of the main hints for you to figure out if it's obstructive or restrictive lung disease is the FEV to FVC ratio. So this will immediately point you to one of the directions, either obstructive or restrictive lung disease. Okay, so I'm just going to explain to you guys what an obstructive lung disease basically means, because this is going to help you remember why you actually see a decrease in the FEV to FVC ratio, okay? So in obstructive lung disease, what happens is that this is a disease of exhalation. The person can't breathe out the air. They can breathe in, that's normal, but they can't breathe out, okay? Why is that? Because the air becomes trapped inside the lungs. They inhale, they're trying to exhale, but the air becomes trapped. And why is that? It's because the airways collapse. We talked about how the transmural or the transpulmonary pressure was consistently positive in the breathing cycle, right? And that was keeping the airways open. But here, okay, in the obstructive lung disease, the pressure actually becomes negative, okay? And that causes the airways to collapse, trapping the air inside the lung, okay? Because the air is trapped inside, the person can't exhale. FEV1 and FVC basically measure the volume of air the person is exhaling. Because that is decreasing, the ratio of these two values is going to decrease, plus the values themselves are also going to decrease. You see that here. So normally you see FEV is like 40, FVC is 5. You look here, you see FEV1 actually has decreased to 1.3. FVC has decreased to 3.1. So of course the ratio also is going to decrease. One other thing is that now because the air is being trapped inside the lung, okay, the person can't exhale the air, the total lung capacity, okay, is going to increase. Why is that? Because now you have more air trapped inside the lung, okay? So you're starting off each inhalation with more air because in the previous cycle, the air wasn't exhaled, okay? It's still trapped inside the lung. So total lung capacity, okay, increases. Same goes for residual volume. What is residual volume, basically? It's the volume of air that's always present in your lungs. Because air is being trapped inside the lung, the residual volume increases. It becomes higher than normal because some air that was supposed to be exhaled is no longer getting exhaled because the airways collapsed and the person can't exhale properly. And that's why basically they have the obstructive lung disease. Now, in restrictive lung disease, what happens? Whereas the obstructive lung disease was a problem of exhalation, restrictive lung disease is a problem of inhalation. What do we mean by that? What happens in restrictive lung disease, basically to simply state, is that you have an excess fibrosis or excess collagen deposition. And what does that actually lead to? If you have fibrosis or excess collagen deposition in the lungs, it basically decreases the elastic ability of the lung. So when you breathe in air, your lung is normally supposed to expand to accommodate this volume of air. But when somebody has a restrictive lung disease, because of this excess collagen deposition, the lungs actually can't hold, okay, or actually can't accommodate to this new volume of air because this fibrosis is happening, okay? It takes away the lung's elastic ability. But what the collagen actually does allow the person to do, okay, is that it increases the recoil force. If recoil force increases, it means the person can actually put in more force during exhalation, right? Because in exhalation, the alveoli actually close in on themselves, okay, in the recoil force and push the air out. The person actually is able to put in more force during exhalation. So you must be thinking that, okay, this person can now put in more force during exhalation. Why are we seeing a decrease in FEV1 and FVC? We should see an increase because they're putting in more force. The reason is because this is a problem of inhalation. They never inhaled enough air for them to be exhaling that air, okay? You need to inhale a certain volume of air in order to exhale a particular volume of air. If you don't have air to exhale, you can't basically exhale even if the recoil force is there. Because the lungs are not accommodating, they can't breathe in sufficient air. So the FEV1 value and the FVC value both decrease, but their ratio actually increases. So it's very characteristic of restrictive lung diseases. Whenever you see a question and you see that the patient basically went to the doctor, we did a spirometry, okay, and the ratio came out to be, let's say 90% or like 91%, basically anything above 80%, immediately restrictive lung disease, okay? Now, talking about residual volume, like I mentioned, because of the excess collagen deposition, your recoil force basically increases for the amount of force that you can exert during exhalation increases. And so the residual volume will actually decrease because this person basically is exerting more force during exhalation. So their residual volume, which is the volume of air always inside the lung, will decrease a little bit, okay? It'll be lower than normal. And because this patient can't breathe in, okay, they can't do inhalation properly, their TLC, okay, or total capacity is going to be lower than normal. So quick summary of both the diseases or both of the pathologies. Obstructive lung disease, problem with exhalation. Airways collapse, air trapped inside, total lung capacity will increase, residual volume will increase, FEV1 to FVC ratio will be less than 80%. Restrictive lung disease, problem with inhalation because lungs are not accommodating because of excess fibrosis. Total lung capacity is going to decrease, residual volume is going to decrease, FEV1 and FVC individual values will decrease, but their ratio is going to increase. Now let's come to this expiratory flow volume curve. Now, again, we're asking the patient, okay, or the person basically, to breathe out, okay, maximally and with much force as possible. In this graph, we actually have two regions. Here, this is actually called the effort-dependent region. Here, the amount of effort or the amount of force the person is putting into breathing matters, okay? Whereas in the effort-independent region, it doesn't matter how much the force the person is putting in, okay? That's why it's called the effort-independent region. So see here, the maximal flow rate that we actually get when the person breathes out forcefully and maximally is called the PEFR, which is peak expiratory flow rate, okay? Maximal effort. So we measure the PEFR of a person, okay? And you can see here, this is with maximal effort, we get a particular value of the PEFR. If the person isn't able to put in that much effort, okay, their effort is going to decrease, and so we're going to get a lesser value of PEFR. Minimal effort is going to be even a less value of PEFR. Along with peak expiratory flow rate, we can also measure three other parameters, okay? We can measure FEF 75, 50, and 25. So what does FEF 75 basically means? It basically means that 25% of the vital capacity has been exhaled and 75% is remaining. FEF 50, 50% of vital capacity has been exhaled, 50% is remaining. FEF 20, 75% of vital capacity has been exhaled and 25% is remaining. You can see that the graph actually ends here or touches the line here, okay? Because after this is residual volume. The patient or the person basically can't exhale this volume of air because it will always stay inside the lungs. This is the effort-independent region, and you can see that even with moderate and minimal effort, all of these graphs connect in the effort-independent region because here, the amount of effort the person is putting in doesn't matter. It matters in the effort-dependent region, which is this part. So when you're carrying out basically this test, you need the patient to breathe as fast as possible and as maximally or as much as possible. So we talked about these parameters, FEF 75, forced expiratory flow rate at 75% vital capacity, 25% vital capacity has been exhaled. At FEF 50, 50% has been exhaled, and at FEF 25, 75% has been exhaled, 25%. It's remaining. Okay, we talked about this as well, effort-independent region, okay? It doesn't matter how much force the person is putting in during this part of the graph, okay? Because resistance to airflow increases proportionally with the alveolar pressure, this flow stays the same. If you want to think about it like logically, if you try to breathe out as much as you can and as fast as you can, there will be a time where even if you are trying to force air out, you still can't, okay? Because you basically have reached a point where you can't put in more effort, okay? And that is the effort-independent region. Here, effort doesn't matter, okay? Because resistance to airflow increases proportionally with alveolar pressure, this flow stays the same. This is basically if you want to look at it in terms of like scientific data. Okay. Changes in flow volume curve in obstructive and restrictive lung diseases. This is actually important, okay? Not just for first year, but also for third year, okay? Because pathologies, they will sometimes show you graphs, okay? And ask you, okay, what's happening here? And you're supposed to know which pathology or which disease actually it is just by looking at the graph sometimes, okay? So let's look at the normal one we just saw. We can see peak expiratory flow rate, okay, which is the maximum flow that we can achieve, okay? And after that, basically the flow eventually begins to decrease, stops here, because after that you have the residual volume. So this point here, this volume of air that you can actually plot here is the residual volume. This is residual volume. This volume of air never leaves the lungs. This volume over here, okay, where you start off, okay, or the total lung volume here, this is the total lung capacity. Okay. Now we come to obstructive disease. Like we talked about, this is a problem of exhalation. We mentioned that some basically air gets trapped inside the lungs. So you can see that your residual volume, which is normally here, has actually now increased to somewhat here, around 4. Same thing about total lung capacity. Usually it's supposed to be somewhere here, it's around like 7, you can say, according to this graph. But now it's actually increased to more than 8. Okay? Because it makes sense. Air gets trapped inside the lungs, total lung capacity is going to increase. Same goes for residual volume. Residual volume is also going to increase because air has been trapped inside the lungs. Restrictive lung disease. Here, you can see the residual volume actually is lower than normal because more force is being put into exhalation because of the excess fibrosis. You're not supposed to have that excess collagen deposition or excessive fibrosis inside the lung. That's a pathology. That's why your residual volume is decreasing, okay? It shouldn't be this less, but it is. Same thing goes for total lung capacity. Because the patient isn't able to breathe in enough air because the lungs are no longer accommodating to air, you can see that the total lung capacity has decreased. Okay? So again, this tells you this is a pathology. The lungs aren't accommodating, the person can't breathe in enough air, total lung capacity decreases, the person is putting in more force during exhalation, so residual volume also decreases. One thing you guys can actually notice here is that the slope of this graph compared to the slope of this graph is actually different. So do you guys know why the slope of a restrictive lung disease actually is more steep as compared to obstructive lung disease? You can see actually it's pretty much normal, almost the same as this one. Do you guys have any idea as to why this is? Any guesses? All right. It's okay if you guys don't know, that's fine. We'll discuss it later on. Or we're going to discuss it now. Basically, the reason being why you actually have a steeper slope is because of the excess collagen deposition. Okay, that allows you, or that basically allows the patient more or higher recoil force. So they're actually able to exhale much more forcefully in restrictive lung disease as compared to obstructive, okay? So the peak expiratory flow rate actually has decreased here because it's a problem of exhalation. They can't actually exhale properly. The slope isn't even close to being normal. Here, it's actually a bit more steeper than normal because of the excess collagen deposition. More recoil force means more forceful exhalation. That's why basically the graph is a bit more steep. Sorry, the slope is a bit more steep for restrictive lung disease. Okay, this is basically a kind of a variation of this flow volume curve, okay? The difference just being that they're showing you inspiratory flow here as well. Over there, they're only showing you expiratory flow. In this graph, they're also showing you inspiratory flow, okay? Just to follow the graph, we can see here that we start from here in expiratory flow, and basically we breathe out as much and as fast as possible, and so the volume basically decreases, okay? And after that, the flow rate begins to decrease because we're not able to put in that much force during exhalation anymore. So volume is still decreasing, but the flow rate basically is decreasing because we're not putting in that much effort or not that much force. Inspiration, okay, or inhalation, you can see here, volume is increasing first by a lot, okay? So the flow actually is very high in this part of the graph, okay? Because you can do maximal inhalation in the beginning. But after a certain amount of time, you can't inhale as much air as possible, okay? And that's why the flow begins to decrease, but volume is still increasing because you're still breathing in air. In this graph, this is your total lung capacity, okay? So the maximum lung volume. This is your residual volume. So the point that would be here. We talked about this, the PEFR, or basically the slope. All right, guys, do you have any questions so far from what we've talked about? Would you like me to repeat something? Because it was a lot of information, a lot of graphs. So do you guys want me to go back and repeat something? Someone asked for this last graph, and of course I can explain it again. I actually didn't see this in your presentation, but the reason I put this here is because I saw it in a few questions. So I was like, let me just show it to them just so they're actually familiar with this, okay? You'll see it in third year as well. So just get familiarized with it. Basically, in this previous graph that you saw, which is in your presentation, why is RB going back? Here. Here, they're just showing you expiratory flow. If I were to take basically or ask you what would inspiration or inhalation look like, it will look like this. Okay, same graph, basically same concept, just for inhalation. Let's talk about it again. We're starting here, okay? The person starts to inhale air, so volume inside the lung begins to increase, okay? We go from this point and we start to increase the lung volume because air is entering the lungs. Lung volume begins to increase. This point is residual volume, which is the volume always present inside the lungs. Okay, we're starting from here because we're basically assuming the person has just finished exhaling. Now they're starting inhalation. So they're starting from residual volume. Okay, let's say they're in distress. So they're basically pushing out all of the air. Starting from residual volume, maximal inhalation. Now this is basically flow. Okay, you can see here that because the person is putting in more effort in the first part, you can try it yourself as well. If you try to inhale maximally, you first are actually able to inhale a lot of air. But you reach a point where even if you're trying your best to put in more force in inhalation, you can't, okay? So the volume of air going through your airway per unit time, which is flow, decreases because you can't, even if you're trying, you can't put in more force. So the flow decreases after a certain amount of time. That's why the flow or the amount or volume of air going through the airway per unit time decreases okay, flow decreases. So you're going from, let's say, like -4 to, let's say, 2, and then eventually like 0. But the volume is still increasing in this graph because you're still inhaling air. The amount of air going through your airway per unit time is decreasing, but you're still inhaling air, so the volume continues to increase. Okay, now you have maximal air inside your lungs, okay? You're at the total lung capacity. Now you need to exhale this air, okay? So when you're now breathing as fast and as forcefully as possible, first, the flow rate is very high. So you're breathing out a lot of air per unit time. A lot of air is flowing through your airways per unit time. So the flow is very high. Okay, you can see it's going from 2 to 4 to 6. Okay, and also like basically reaches 8. Now, however, you reach a point where even though you're trying to push out more air, you can't. So eventually, the amount or volume of air going through your airway per unit time begins to decrease, which is why the flow starts to decrease. And that's what basically this graph is showing you. But because you're still exhaling air, you are still decreasing the volume inside the lung. And that's why you're going from 5 to 4 to 3 to 2 to 1, okay? Eventually, you've exhaled maximal air, and now you're at residual volume again. The cycle starts again from here. So inhale maximally. Initially, you're doing it very, very much, okay? That's why flow is very high, but you reach a point where you can't do it with that much force anymore, so flow decreases. But because you're still inhaling, the volume of air is still increasing from 2 to 3 to 4 to 5. Now you're exhaling with a lot of force, so flow is very high. But you reach a point where you can't do it with that much force anymore, so flow begins to decrease, but you're still exhaling, so volume is still decreasing. So to the person that asked me this question, does it make sense now? All right, great. Okay. So basically, he talked about this in your recording. He didn't really put the slides in the lecture itself, but I just thought that I would go over just in case. I don't think that you have to know details about obstructive lung disease and restrictive lung disease at your level, but because he mentioned it in the lecture, let's just go over what he said, okay? All he's trying to tell you, or basically explain to you, is that why in obstructive lung disease the person has an issue with exhalation. So we talked about airway collapse, right? Why does that happen? What's the science, or like what's the mechanism behind this airway collapse, okay? So during exhalation, basically, you have the chest wall, which basically helps the lungs, okay, during the breathing cycle. The chest wall basically begins to put in pressure, okay, around 30, okay? And now this pressure that is being exerted by the chest wall onto the lungs is also transferred to the alveoli because they have a thin membrane. Inside the alveoli, you also have the recoil force, okay? So the recoil force also exerts a pressure in the alveoli of about 20. Pressure is also being exerted by the chest wall, which is 30, like we talked about. So total pressure inside the alveoli is 50. Now, we talked about in the beginning about two basic concepts. You need to have a pressure difference in order for air to flow from one location to the next location. Second basic concept, the air will flow from a high to low pressure. High pressure right now is inside the alveoli. Low pressure is in the atmosphere, which is 0. So air is going to flow from the alveoli outside into the atmosphere. As the air begins to flow through the basically airways, it basically decreases its pressure, okay? Its pressure begins to decrease. Now, at this point, at 30, the pressure across the wall, or the transmural pressure difference, is equal, okay? It basically is 0. The pressure outside the wall or across the wall, basically, and inside the wall is now the same. After this, transmural pressure difference actually will now become negative. It'll become -10. Okay? Now, I told you guys in the beginning, in the breathing cycle, when we were discussing it, that I told you transmural pressure difference is basically positive throughout this breathing cycle. And that's preventing the airways from collapsing. Okay? Now here at 20, now this pressure actually inside the airway is less than that outside. 30 minus 20, you have minus 10 here. Sorry, 20 minus 30, you have minus 10. So a negative pressure inside the airway means the airways are not going to try to collapse. Okay? If this happens, for example, in a healthy person, usually you reach this negative pressure in a very strong and thick-walled airway like the trachea. A trachea has a very thick wall. It's a very strong airway. So even if you have a negative pressure inside the trachea, it will not collapse because it's strong, has a very thick wall. Okay? And then you will exhale that air. Okay? However, in an emphysema patient, okay, or like, for example, in an obstructive lung disease patient, this point of where the transmural pressure difference is 0, okay, is actually pushed at a point where it's in an airway that is not as strong. It's a very weak airway, has a very weak or thin wall, and that means that when there is a negative pressure inside the airway, it's going to collapse and trap this air inside the lungs, okay, and the person can't exhale. So basically, this is where he's showing you the transmural pressure difference, okay? And he showed you that here it becomes 0, and after that it becomes, the transmural pressure becomes minus 10. This is an explanation of basically what I just mentioned. You guys can read that at your own pace. So this is important. Depending on where this point falls, okay, you can determine if the airway is going to collapse or not. In a healthy person, this point usually occurs in a strong, thick-walled area like a trachea, thus there will be no collapsation or collapse of airways. Normal exhalation. In an obstructive lung disease, it usually happens in a weak airway. Now, if you think to yourself, okay, maybe this person who has an obstructive lung disease can exert more force, okay, in exhalation. That might actually make the situation better. However, that's not the case. Why is that? Okay, let's say this person now is trying to put in more force during exhalation, okay? So they use their accessory muscles, they use their chest wall to put in more force during exhalation. So in our previous example, the force, or basically the pressure being exerted by the chest wall was 30. We increased it to 50. Okay, so the pressure outside 50, which is now being transferred to the alveoli, total pressure becomes 70. And we present that in this graph here. So total pressure in the alveoli basically is 70, okay? And the pressure exerted by the chest wall is 50. In our previous example, this was the case, that we had a pressure exerted by the chest wall was 30. We see that here. And the total pressure in the alveoli, or the alveolar pressure basically, was 50. Now, these dots tell you where there is an equal pressure inside and outside the airway. You can see that when we try to, or basically when the person puts in more force during exhalation, this point is reached quicker. Usually it happens here, it happens later on, like we talked about, it happens in an airway which is strong. It can actually stand that negative pressure until the air is basically exhaled. But because this point is being pushed closer to the alveoli and thus being pushed into an airway which has a weaker wall, it means that this airway is going to collapse. Okay. And thus putting in more force won't actually help you because, again, it will further push it into an airway, which is, again, weak and can't withstand this negative pressure. So what can these people actually do? Okay, you will see sometimes that people who have emphysema or basically have an obstructive pulmonary disease, you will see that they are breathing with pursed lips. Okay, why does that actually help? It helps because when these people purse their lips, okay, it creates a resistance, okay, to air. And that means that because there's an increased resistance, now in order for the air to basically be exhaled, it's going to increase the pressure of air. And that will allow it to basically be exhaled out of the body. So people who have an obstructive lung disease, you'll see they're breathing very, very slowly, and they're breathing with pursed lips. Okay? It creates resistance and basically back pressure, which basically allows the air to be exhaled. So what we need to remember here is the fact that pursing their lips helps them exhale. Because you can see that the point of equal pressure is reached later on with pursed lips. Now, you must be thinking to yourself, why is emphysema not an inhalational problem? Before we go to this, do you guys have any questions about why it's not an exhalational problem? Is that so far clear? Guys, I can repeat it if you want. Is it clear? All right. So it's clear to everybody. Now we can move to why it's not an inhalational problem. Okay, so when I was explaining obstructive lung diseases to you, I mentioned that air is trapped inside the lungs. It's an exhalational problem. They can't exhale air. Why is it not an inhalational problem? So Dr. Shams explained it by showing this to you. During inhalation, the chest wall is basically expanding, okay? It's moving in the opposite direction. It's exerting pressure in the opposite direction. So you have minus 30. That's transferred to the alveoli. Alveoli has always had a recoil force, okay? Remember, when you have an elastic, for example, an elastic organ like the lung, and it has the elastic ability, yes, it can expand, but it will always try to come back to its original shape. Okay, the recoil force will always be there, which is what we see here. The plus 20 is the recoil force. Total pressure of minus 10. Okay. Now, air is going to rush in from the atmosphere, basically into the alveoli. And if we were to calculate the transmural pressure, okay, you can see it's always positive. So the airways aren't going to collapse, okay, because the pressure is positive. So air can very easily enter the lungs, okay? And the lungs are compliant. They can actually expand, allow this air to enter. The problem lies in exhalation, where the airways collapse and the person can't exhale, okay? The air becomes trapped inside the lungs. So positive transmural pressure means no collapsing of airways, okay? Air can very easily enter. The lung is very compliant, very accommodating to this entering air. All right, guys, we finished pulmonary function test, okay? Do you guys have any questions from any part of this lecture? Would you guys like me to repeat anything before we go on to the questions? Because it's the last checkpoint before questions, if you guys have any concept that you want me to repeat, we can do that now. And then move on to the questions and we can solve it together. Okay, someone asked for recap of the last bit. Yep, we can do that. So all basically he's trying to tell you here, why it's not an inhalational problem is because the transmural pressure is always positive, okay? That means that the airways actually collapse when the pressure is negative. The transmural pressure is negative. That causes airways to collapse. In a healthy person, there will be some times when there will be a negative pressure in the airway, but that usually happens in a very strong, thick-walled airway, like trachea. for example. The trachea won't collapse when you have a negative pressure inside it, okay? Because it's very strong. If the transmural pressure is positive, the airways won't collapse. Like we see here, -8, okay, you see a transmural pressure of +22. For -5, you see a transmural pressure of 25. Here, you see a transmural pressure of 28. So throughout the inhalation process, the transmural pressure is continuing to stay positive. So there's no reason for the airways to collapse. The air will very easily go inside the alveoli during inhalation. The problem is in exhalation where the air is trying to leave and there is a negative pressure in a very weak airway with a thin wall. It can't resist collapsing because it has a very thin wall. So we can go over the explanation that I wrote here as well. In inhalation, the inspiratory muscles are contracting. They produce pressure in the opposite direction outward, so the airways stay open. Even at the lowest pressure, which is -10, the transmural pressure difference is +20, so the airways remain open. Inspiration is mainly an issue in restrictive lung disease because the recoil force is high, so a higher pressure has to be generated by the inspiratory muscles in order to expand the alveoli. So inhalation is not a problem in obstructive lung disease. It's a problem in restrictive, because in restrictive, the lung loses its elastin stability, okay? And the recoil force becomes very, very high. Compliance is lost, recoil force very high. So the lung will not accommodate a large volume of air inside it. Is that clear? Your question? All right, let's go to the questions now. We can go to the summary as well. So a spirometer is used to check pulmonary function. It helps you measure FVC, FEV1, ERV, IRV. It can't measure TLC, FRC, as well as RC. This ratio helps you diagnose any lung pathology. Usually it's supposed to be 0.8. If it's lower than that, it's an obstructive lung disease. Higher than that, restrictive lung disease. We use a flow volume curve to diagnose lung pathologies, and it can help us measure parameters like peak expiratory flow rate, FEF 75, 50, and 25. All these parameters actually are going to be decreased in obstructive lung disease, okay? They're also going to be decreased in restrictive lung disease. However, if you look at these parameters in comparison to TLC, total lung capacity, they're going to be increased or normal. This is important. We talked about effort independent region in the flow volume curve, okay, where it doesn't matter how much effort you're putting. The peak expiratory flow rate is low in both types of diseases. However, in restrictive lung disease, the slope is higher because it's more force generated in exhalation. The recoil force we're talking about here. In emphysema, the airway collapses, trapping the air within the lung as a problem of exhalation, during which gets better by pursing of the lips because it creates resistance to the air, okay? Basically allows it to be exhaled because it increases the pressure as well. All right, practice questions. Would you guys prefer me to read or you guys want to do it on your own? All right, you know what? I'll give you some time to read it on your own, and then we can basically discuss it together. I'll read it, and then we can do it. So what do you guys think here is the answer? Okay, someone already answered. Okay. All right, so most of you are saying A, which, yes, it is the right answer. And we talked about it in this slide where I told you 3 things can't be measured: residual volume, functional residual capacity, and total lung capacity. Okay? Oh, yeah, okay. Now this next question. All right. A lot of you have said E, which actually is yes, it is the correct answer. And why is that? Because we talked about how in the equation for resistance, the radius has a power of 4. So they're telling you they're reducing the radius of an airway to 1/3, okay, 1/3. Put it to the power of 4, you get 1/81. So resistance increases by how much? 81. That's your answer. We talked about this over here. All right, guys, next question. This question like maybe a bit new to you guys, I think, and that's okay. Just guess. Okay. So, I'm seeing a bit of mixed answers here, and that's okay. Let's actually talk about this in detail. Okay? Now, we have a 12-year-old boy who had a severe asthmatic attack. What happens in asthma? Okay? You can think about it in terms of an allergic reaction. And I mentioned like histamines, which cause bronchoconstriction. Okay? So in asthma, basically, you have bronchoconstriction. Okay? So increase in resistance to airflow, sorry. Now, he experiences rapid breathing and becomes cyanotic. His arterial PO2 is 60 and PCO2 is 30. To treat this patient, the physician should administer what out of these? Okay, so answer this question to me. Which nervous system actually can kind of relieve this patient's symptoms? Okay, is it the sympathetic nervous system or the parasympathetic nervous system? It's obstructive. You only consider it in that way, but don't think of asthma in terms of like restrictive or obstructive. That's not the correct way to kind of approach this. Basically, this patient is having an asthmatic attack. He is having bronchoconstriction. and he can't breathe properly. Okay, don't think of asthma in terms of restrictive or obstructive disease. That's not the correct way to do this. He has bronchoconstriction. We need to give him something to cause bronchodilation. So the nervous system that we actually have to activate here is the sympathetic nervous system. Okay. And why is that? Because we mentioned sympathetic nervous system is activated in the fight or flight response. If you are running away from danger, you need maximum amount of oxygen in your body, to your muscles, to your organs, okay, to function well. What you need here is to activate the sympathetic nervous system, okay? The sympathetic nervous system actually has receptors called beta 1, beta 2, okay? The particular one that you need here is beta 2 adrenergic agonist. You guys know what agonist and antagonist means, right? Agonist means it will stimulate that receptor. Antagonist means it's going to inhibit that receptor. B2, okay, particularly this receptor, is present on your bronchi, okay? If you were to go and basically stimulate beta 2 adrenergic receptor, it's going to cause bronchodilation. That's why C is actually the correct answer. And it's not D, it's not muscarinic or nicotinic agonist, because these are actually neurotransmitters of the parasympathetic nervous system. If you were to activate the parasympathetic nervous system here, it would cause further bronchoconstriction. Okay, we don't want that, because due to this patient's asthma, he already has bronchoconstriction. So you want to do bronchodilation. Think of a severe allergy, okay? Severe anaphylactic or severe allergy attack. What happens? You'll see something in movies or like in TV shows. People are going to be saying, get an EpiPen, get an EpiPen. What is EpiPen? It's an epinephrine pen. Epinephrine pen, okay, or epinephrine basically is the neurotransmitter of the sympathetic nervous system. So when epinephrine is released into the body, it goes and binds to the B2 adrenergic receptor. It stimulates it and causes bronchodilation. Guys, does that make sense? Or should I repeat it? All right. So I actually don't think that he will get you questions with this much detail, but you never know. So just understand it. Okay, it's a pretty simple concept. B2 receptor present on the bronchioles, when you stimulate it, it's going to cause bronchodilation. And this is what I was talking about. So sympathetic innervation is going to decrease airway resistance because it causes bronchodilation. All right, next question. Guys, read the question properly. All right. Okay. Okay. So sometimes professors will actually trick you. Okay, they won't bold the key word in the question. Okay, which is, by the way, so rude. But the way you can actually lose marks in questions is by not reading it properly. You're maybe out of time. You may not read it properly, and you can lose marks even though you know the answer. So the key word here is normal expiration or normal exhalation, not maximal. It's normal exhalation. This person is at rest. Okay, they're breathing normally, so they're doing tidal volume. Okay, breathing normally means what is going to remain inside the lung? FRC, functional residual capacity. The answer is A. So functional residual capacity is the volume of air present in the lungs when a person normally exhales. Next question. All right, awesome. You guys are correct. The answer is D. Why is that? It's because we talked about radius is the most important. It has a power of 4. A very small change in radius will create a very, very strong change in resistance. Next question. Okay. Guys, there's around 6 of you here, but I'm only seeing response from a few of you. For the rest of you, do you guys have some sort of confusion that you want me to answer? Okay. Yes. So for this question, the answer is actually B. Why is that? Your focus has to be on this ratio right here. The FEV1 to FVC ratio. This is going to help you so much, okay, in figuring out the pathologies. Right now, it is 86. The normal value is 80. We talked about how if the value is higher than normal, yes, we figured out if the value is higher than normal, which is 80% or 80, that is restrictive lung disease, because a greater recoil force, more, you could say, effort, more force is being pushed into exhalation. And whereas with an obstructive lung disease, the FEV1 to FVC ratio actually is going to be less than normal. Okay? That's why the answer here is B, because it's more than normal. It's 80. So it's characteristic, you can kind of say. So when you're actually doing like clinical scenarios, okay, you will see this a lot of times. We'll see like a patient who has like symptoms of like a lung disease. They'll come to your clinic and they'll say they did like a spirometry. They measured FEV1, FVC. They calculated the ratio. It came out to be more than 80%. So 81, 82, 90, 96, whatever. More than 80 means restrictive lung disease. All right, guys, this is your next question. So go back to the concept of like individual airway and the generations. So like the collective diameter and it being higher in certain generations as compared to others. Okay. So the answer here actually is A. Now, remember we talked about the terminal bronchioles and we talked about the trachea, and we said that in the generation of terminal bronchioles, you have 30,000 terminal bronchioles, and you add the diameter, or you basically add the radius of all of these terminal bronchioles. So it comes out to be more than that of the trachea, correct? So resistance is less in the terminal bronchiole as compared to the trachea. Because you have, let's say, 30,000 terminal bronchioles, okay, you can kind of apply the same concept here, is that you have more bronchiole than you have a bronchi, more bronchi than you have a trachea. So you have one trachea, and then you have like two main bronchus or two main bronchi, and then segmentation happens and happens and happens, okay? So as you move further along the generation, the number of airways in each generation begins to increase. So you have one trachea, two main bronchi, okay? And then more proximal bronchi, and then more segmental bronchi, and then more terminal bronchioles. So because you have more terminal bronchioles, okay, the generation of terminal bronchioles has a higher number. Basically, a change in the radius in this generation is going to cause a bigger change in the resistance as compared to if you change the radius, for example, the trachea, because you only have one trachea. If you change its radius a little bit, it won't really cause that much of a change in resistance. But you have 30,000 terminal bronchioles, okay? And you change the radius, okay, or the diameter, for example, of all of these 30,000 terminal bronchioles, okay? And like we said in that concept, we consider generations. We don't consider individual airways. So now in this generation, you have 30,000 terminal bronchioles. You change the radius or change the diameter of all of these 30,000 terminal bronchioles. It's going to create a greater change in resistance because the total collective diameter of terminal bronchiole is more than that of the trachea. Does that make sense, guys? Do you guys get why it's A? Great. So think of changing the radius of 30,000 pipes as compared to changing the radius of one single pipe. Which is going to have a greater change or a greater effect? 30,000 pipes, right? So that's basically the concept here. I hope that's clear enough. All right, guys. Next question. This one. So this time, guys, read the question properly again. They can very much play with words, and it will very much change the answer to the question. Yes. MashaAllah, all of you guys are doing amazing. The answer is B, because now we have maximal exhalation. In the previous question, we had normal exhalation. That's the difference. So, residual volume is always in the lungs, and it's the volume that's going to be present after maximal exhalation. Why? Because when a person does maximal exhalation, they're removing expiratory reserve volume. Okay? Oh, I don't have the graph here. Let me quickly go back and show you which graph I'm talking about. here. So normal exhalation and maximal exhalation. When a person does maximal exhalation, they remove ERV as well. Excuse me. In maximal exhalation, this is gone as well. So only this is left. If it's normal exhalation, you have this plus this. So if they say which volume is remaining after normal exhalation, it's FRC. If they ask which volume remains after maximal exhalation, residual volume. Okay. We did this question, yes? Yeah. We're on this question. All right, guys, this is the next question. Yes, exactly. The answer is B. You guys are doing amazing, mashallah. So think of compliance and recoil as kind of opposites to each other. Recoil wants to basically pull the lung back into its original shape. Compliance allows the lung to basically expand and accommodate more air. So what happens to compliance when recoil increases? It decreases. This is actually what happens in a restrictive lung disease. Recoil increases, so compliance decreases, thus less air can enter the lung. That's why it's an inhalational problem. All right, guys, this one. This is your next question. Okay. So, okay. So some of you are saying B, some of you are saying A. Okay. Now, they're asking about a 22-year-old college student who's undergoing an experimental pulmonary function test. You can see his flow volume loop, okay? The generation of which part of the loop is dependent on the individual's effort during expiration. A simple way of phrasing this question would have been, which part of this graph is the effort dependent part of this graph? That's what they're asking you. Which part of this graph is effort dependent? That is actually A, okay? So always remember the initial part of your flow volume loop, okay, is going to be the part that's going to be effort dependent. Why is that? Because, try it yourself actually. You're exhaling air. Try exhaling the maximum amount of air that you can. You'll see initially, you can do it forcefully. You can do it well. You can put in a lot of force of air, okay? But you'll reach a point where even though you're trying to put in force, you can't. And that is the force independent, because you reach a point where you can no longer exert force during exhalation, even if you're trying. That is the part where flow actually begins to decrease, which is actually, this part. If I were to divide this curve into this and this part, this is the force dependent part. Here, it matters how much effort or how much force you're putting into exhalation. After this, when flow begins to decrease, what is flow? Volume of air going through the airway per unit time. If you're putting in less effort, less air is going to go through the airway. This is the effort independent region, okay? Here, actually, everybody can't put in enough effort. That's why flow begins to decrease. And that's why this is called the effort independent region. If you want to see this on the graph that Dr. Shams put in his presentation, okay, you can see that right here. The initial part is the one which is part of the effort dependent region, which is the initial part of this graph, which is what we see here in A. Guys, does this make sense? I can repeat it. All right. Is it clear to everyone, this concept? So just remember that in both inhalation and exhalation, okay, remember that initially you can put in effort. Everybody can, okay? So for example, in this flow volume curve, okay, if you think this is difficult, you can look at this one. In the beginning part of this graph, you can see that we're actually measuring how much effort the person can put, because it matters in this region. However, here, we're not looking at how much effort they can put, because everybody can't put in effort in this region. It's not possible. You lose that effort. Okay? So you can only put effort in the beginning part of the flow volume curve. Okay? If you want, you can basically ignore the bottom part of this graph in this question. Okay? Just look at the expiration right now. So A basically is the region where you're putting in maximal amount of effort during your inhalation. They're asking you, where is this individual putting in the maximal effort during expiration? Do you guys understand why the answer is A? Okay, I see one person said that it's clear, but what about the rest of you guys? Do you want me to re-explain it? All right, great. So, this is your next question. Oh yeah, guys. So there are no options here. Just look at here. So A, B, C, D, E. Which point? So which point in this graph, which letter is the point that indicates total lung capacity? Okay. All right. I see some of you have answered. Okay. All right. So the answer here actually is E, okay? And why is that? Okay. Look at here, the lung volume. So 1 second. Look. Extrapolate here, extrapolate here. Some of you said C, okay? If you look at the volume at C, it's actually very less. It's around, like, you could say 1.5 liters, okay? If you look at E, it's actually 6.5 liters, okay? Another way to look at it, actually, is you can see that this graph represents inhalation. So the person starts here at this point. They start to inhale at this point. You can see the volume goes from 1.5 liter to 6.5 liters, okay? And then the person stops inhaling here. They can't inhale more air than this because they're at their total lung capacity, which is point E, which is what point E is trying to basically represent here. Okay? C actually, what do you think? What do you guys think now that I've explained this? What do you think C is? What does point C represent? What volume? So the person is starting to breathe, okay? And when they're starting inhalation, they have some volume in their air, okay? Which they didn't exhale, okay? After exhalation. C actually is residual volume, okay? Because this, yes, exactly. This person, okay, did exhalation, okay? Their volume decreased, their lung volume began to decrease, exhalation right here, okay? Their lung volume began to decrease, okay? Let me actually remove all the ink here. So their lung volume began to decrease, but the airflow stopped at point C, which means they could no longer exhale air. If point C was FRC, there could still be more flow. So the graph wouldn't actually touch zero. The flow wouldn't become zero. Because in FRC, remember guys, the expiratory reserve volume is still remaining in the lung. So we can still remove expiratory reserve volume. Okay? So the flow wouldn't become zero. There's still some air left, which we can exhale. But at residual volume, you can no longer exhale any more air. So now, that's why point C is residual volume, because the flow becomes zero. You can't exhale more air. Okay? And you can also think about why C is not total lung capacity. It's Y is residual volume and not total lung capacity. Because look at what number it's representing in the lung volume, 1.5. E represents 6.5. Okay, this is just to help you. But the main reason you can see is that because we start inhaling air at point C, volume increases, we reach point E, after which flow becomes zero. Why? We can no longer inhale more air because we are at total lung capacity. Guys, is this clear? Do you guys get why it's not C, why C is not total lung capacity, and why it's E? And also as to why C is residual volume. Great, mashallah. You guys are doing amazing with these questions. All right. End of the session. Could you guys please scan this QR code? It's only one question, and it's going to help me improve my next PAL sessions. So please scan this QR code and give me any feedback. Do you guys have any questions from any point in the lecture? I can repeat it. It can just be us in this lecture, and we can go back and repeat something if you didn't understand. Or if you have any particular questions, we can answer them now.